Hello, everyone. Welcome to today's episode of CAFC Presents. I'm Doug Maynard. I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centers. And today's webinar, which is part 2 of a 3-part series on social pediatrics, is called The Paediatrician as Child Advocate and Child Protection. Our previous episode in this 3-part series was done about 2 weeks ago, I think, and it is up and available on the Knowledge Exchange Network. And it was a great sort of background introduction to the concepts of social pediatrics and using school-based programs as an example. So I encourage everyone who didn't see that to go to the Knowledge Exchange Network and take a look at that. There's also an opportunity for registered users of the KEN, and anyone can register an account on the KEN to post comments or have any kind of a discussion around the content that's on that page as well. So we encourage you to join that discussion and following the presentation and post any other additional information or comments that you might have. So without any further ado, it's my pleasure to introduce our speakers. With us as our sort of co-host of this series is Dr. Dennis Danneman, who's the Professor of Pediatrics and Chair of the Department of Pediatrics at the University of Toronto, Faculty of Medicine, and the Paediatrician in Chief at the Hospital for Sick Children. And of course, you'll recall him from the first episode of this series. And joining him is Dr. Lee Ford-Jones, who's an infectious diseases specialist and clinical researcher, also at the Hospital for Sick Children in Toronto, and also a professor of pediatrics at the University of Toronto. And she holds a special interest in vaccine-preventable diseases, childhood encephalitis, congenital infections, and infections in day center attendees. And since 2007, Dr. Ford-Jones has led a new educational initiative in social pediatrics that targets the disadvantaged. We also have with us from the Children's Hospital of Eastern Ontario, CHEO, in Ottawa, Dr. Sue Bennett, who's currently also a professor of pediatrics at the University of Ottawa. And she's also an associate at the International Institute of Child Rights and Development at Royal Roads University and a board member for the International Society for the Prevention of Child Abuse and Neglect. And also joining us is Dr. Jean Clinton, who's an associate clinical professor at the Department of Psychiatry and Behavioral Neurosciences at McMaster in the Division of Child Psychiatry. And she's also on staff at McMaster Children's Hospital and an associate in the Department of Child Psychiatry in University of Toronto at Sick Kids. And is also a member of the Offord Center for Child Studies and has been a consultant to child welfare and children's mental health programs for over 25 years. So we certainly have a true panel of experts, and it's my pleasure to hand the virtual podium over to Dr. Dennis Danneman.
So the first slide is just an introduction to this webinar series, a webinar series in 3 movements sponsored by PTC and CAFC. Doug is the producer of this and has done a fantastic job, and we should thank him very much each time. I'm the director, and Pediatric Chairs of Canada, together with CAFC, wants to make sure that we do everything in our power to ensure that the child health and well-being agenda is not left out by the provincial governments or the federal government. And as we said last time, Jeffrey Simpson gave a talk at CAFC at the Coalition and PTC Symposium prior to CAFC, in which he said he could not find child health and well-being on the agenda of either the provinces or the federal government. So this is one of those occasions where we can all talk together. We may be preaching to the converted, but at least we have a chance to talk together and advance the agenda. So the first one took place a couple of weeks ago. It was an introduction to social pediatrics that I gave, and then we focused on education as a mediator of health outcomes. Arjuman Siddiqui of the Jalalana Faculty of Public Health at the University of Toronto did a fantastic job of talking about how good educational outcomes are associated with better health outcomes, and vice versa. And she's a obvious person who has worked with Clyde Hertzman and follows on the traditions of Clyde Hertzman. Mariam Mehta from the University of Saskatoon has done wonderful work as a pediatrician inside the school system in Saskatchewan, and she talked about her experiences there. So education is obviously one of the mediators of child health outcomes, both in the direction of education, better outcomes, and worse health care, if you will, less good education. So those are very important. So we move on to today, where we're focusing really on the pediatrician as child advocate and our role in child protection. And Lee Ford-Jones is going to give the introduction. Jean Clinton is going to talk about leveling the playing field, and Sue Bennett, when is the child at risk. And one thing you cannot say about today's panel is that they're not passionate about their topics. You won't find a more passionate group anywhere in Canada for sure, and probably anywhere in the world on these topics. And on May the 7th, we hope to have we will have the third, which will focus on vulnerable children, with Mike Moffat from Manitoba talking about Aboriginal children, Elaine Tulani from Toronto talking about inner city youth, and then John Wittenberg talking about developing a child health curriculum. What are the things we need to think about as we go forward? So I'm going to stop there and introduce the first speaker, who's probably known to everybody on the line. Lee Ford Jones is as passionate an individual as you'll ever find anywhere on issues of social pediatrics and child health and well-being. So, Lee, it's over to you.
Thanks so much, Dennis, and hello, everyone. Just by way of introduction, it's worth noting that both the goals of improving understanding and identifying and taking opportunities for action are important. Below the arrow here, you can see 3 proposed areas to target, and that would be the areas of poverty and disadvantage. So the two things to stress at the beginning are just that the goals of improving understanding and identifying and taking opportunities for action are both meritorious. The 3 areas that are problems that we really need to target are poverty and disadvantage and access to consistent comprehensive primary health care, such as we heard in the last wonderful webinar, and thirdly, toxic stress. We can start with looking at neglect, which in childhood is at least as damaging as physical or sexual abuse in the long term, but has received the least scientific and public attention. However, it's good to note that the understanding of neglect through education around EB3D, or experience-based brain and biologic development, is progressing really quite well with things such as for fathers through the Father Involvement Initiative, a wonderful booklet, and the work that our colleagues in infant mental health promotion are doing with judges in the courtroom, so that they no longer will say, oh, it's just neglect. They understand the implications of that. Moving along the life trajectory to youth, we can see that the 21st century deaths in 15 to 24-year-old males, and this is in high-income countries like Canada as well as middle and low-income countries, is actually 2 to 3 times higher than 1 to 4-year-olds due to violence, transportation injuries, non-intentional injuries, and suicides. And the authors indicate that the way out of this are the 4 E's of education and employment, engagement, and empowerment. Over the past 10 years, youth homicides in Toronto community housing, at 155, is equivalent pretty much to the numbers of Canadian soldiers who've been killed in Afghanistan in the same time period, 158. The roots of violence have been really very, very thoroughly explored, and that includes co-authorship by the former Attorney General and Chief Justice, whose work is obviously weighing evidence, and he highlights the roles and note the particular order of social exclusion, racism, and poverty as leading to violence, and details forward in this report a very, very wonderfully comprehensive way of proceeding. If we continue looking at the Roots of Violence report, we can shift back to the middle childhood, that 6 to 12-year age period that hasn't got the attention till recently that it so urgently deserves, and that would indicate, well, that would be in their statement somewhere early on in their report. We don't want to overuse the word shocked in this report, but we were shocked that there is nothing for children to do after a short school day, a short school week, and a short school year. Turning then to the national study by the Boys and Girls Clubs of Canada, they note that about 2/3 of children come home to no one, very small percent have after-school programs, and that 4-hour after school period is a time of assaults and injury, and parents are concerned about this. I should also mention that the pediatric residents in various areas have become extremely involved very constructively in middle childhood activities and initiatives appropriate to the pediatric residency training program and CanMed's goals. Just to further prove that we can indeed help children all along the life trajectory, it's worth noting the story of Eric Lemaze, the Olympic gold medalist from the Beijing Olympics. And he actually, in Montreal, was born to a mother who used cocaine, unknown father, alcoholic grandmother with whom he lived, mom in jail, and by grade 7 was not on a good trajectory at all with in school attendance and substance abuse. And he goes on to say that you need a second or third chance. But this does just provide a wonderful example of what happens when a youngster finds something that makes his heart sing, gets the scaffolded learning and relationships, and can proceed. continuing on the theme of improving understanding, home visits would seem absolutely fundamental. And of course, those of us who trained back in the ages of the 1970s certainly got home visits in different ways. And we now here consider the role of home visits to be utterly fundamental to the social pediatric training. And thanks to the wisdom of the medical director of the Children's Aid Society of Toronto and his careful planning with his wonderful team, it's been possible to maintain home visits in the roster. And by going to places such as you see depicted in this Toronto Star photograph, the trainees learn, medical students and residents can see firsthand the vital, fundamental importance of opportunities for families to go to early years centers, community centers, libraries, after-school programs, and partake in community policing initiatives, which gets them walking up the CN Tower or doing all manner of skill building and interesting things. Turning then to what the residents and medical students are finding in these home visits and what they've gone on to publish in a few particular cases. One pediatric resident said, "What they call home has transformed my understanding of the impact on health." And she goes on to say she had with this teen mother, she didn't know where the baby would crawl and walk. In another home basement, the fridge was empty and the stove was very worrisome, and there just weren't books or building blocks. Another medical student said that never again will she advise a patient to take antibiotics with food without worrying if they have food to eat at home, because when she asked an 18-year-old or suggested to an 18-year-old who was having some issues around taking antibiotics, that said, "You'll feel better if you take them with food," the 18-year-old said she didn't have any. This medical student further saw infants in tiny dark apartments in Toronto where the electricity had been turned off. Another medical student honed right in on the two principal mental health questions. How did you sleep last night, and have you eaten today? She could see how the mother slept because there were blankets on the floor of this Toronto apartment. That's where the mother slept. It was a lovely crib, actually, for the baby. Mid-afternoon, "Have you eaten today?" Mother said no. Well, we all know this so very well, the social context in which this is happening, the widening disparity, the polarization of money and resources, and we know this is related to sweeping changes in technology and globalization. If we've seen the JAMA from March 5th, just this year, a wonderful editorial by Neil Halfon says that these problems are not due to business cycle fluctuations, but are actually structural deficits and fundamental shifts in how our economy is structured, with fewer high-paying jobs and, frankly, an educational system that just cannot fulfill the demand for skilled workers. And he goes on to tell us that these structural deficits make it difficult for many parents to invest in the goods, services, and time that promote optimal neurobehavioral development in their children. And we need to provide a ladder of opportunity with the rungs more closely spaced. And these ladders, by the way, need to be transformed from the bottom up. If you've ever wondered if adding income and jobs to families would help, there's evidence that it does reduce conduct disorders in studies in American Indian populations with income intervention of opening a casino. Disruptive behavior of children went down, parental engagement went up. Conduct further, in this particular March issue of JAMA, there's a study over a number of years in a very large population, again an income intervention, and the economic resources were increased, and improvement in childhood overweight and obesity as well. Well, turning then from understanding to action, there's a little litany of things here that have been explored by many people, and just to summarize them, a social history mnemonic. It helps, and we'll look at these again in a moment or two. A pediatric poverty tool, which makes it maybe easier for pediatricians to get financial resources that are needed into the home. An office-based speech and language tool, since there is a weight, and that's so fundamental to all children, and certainly children at risk. Connecting with local resources in very specific ways, so that it's not just connect with your community, but pediatricians need to know exactly what the resources are in a manageable, accessible way. Referral to early years centers, which in many cases are real hubs of support for the families. They do provide access to everything that's going on in the community, rather than just a specific site of development and play-based learning for children and support for moms and dads. Care in new settings was wonderfully discussed last week with respect to schools, but pediatricians are also working in community health centers, and mobile units are being explored, and clinics for the uninsured. I know a number of Canadian children's hospitals have. And then the role of new team members like lawyers is invaluable. The Canadian Paediatric Society, just to focus on two of their spectacular position statements, include the one promoting literacy in the physician's office, which is underutilized. I think it would be fair to say quite profoundly underutilized, and could be explored in one way or another. And vision screening, in a new statement, great new statement, just revisited this year. But then we still need to get at the issue of access to the proper eye exam by an optometrist and the provision of costly corrective lenses. And finally, just a role for a knowledge broker. So let's just look for a second at a couple of these in a little bit more detail. The social history, it helps mnemonic, and the references for the detailed questioning is there if you want it. But really taps into the domains of income, and I guess this is something to think of when we're seeing any patient and wondering what the compliance with our management recommendations will be. What are income and food security issues for this family? Transportation, housing, education, literacy, legal needs, personal safety inside and outside the four walls of their apartment, and what sort of supports do they have. We thought, since that could be, take a while to go through in a busy clinical setting, with our wonderful chief of social work, were there a few questions that we could actually have the pediatrician reasonably ask? Maybe not all of them, but even 2 or 3 of them. And could we have the answers there relevant to the community so that actually the questions would be asked and some information can be provided? And posted there at the websites in this PEDS Poverty Tool, you can see this in greater detail. Well, you can see this document. And I want to just mention that the University of Manitoba has in draft a very wonderful development from this and some comprehensive work they're doing around it. And I believe 2 other provinces are also working on this or exploring it in some way. So the questions were, do you have trouble making ends meet, feeding your family, paying for meds, child tax benefit, any legal issues, safe place to live, need any help caring for your child? Well, even something like those 3 or 4 questions, I think a number of pediatricians are going to say they just aren't resourced time-wise or anything else to explore. And so one could say that you could take that and put it so that no door is the wrong door, that wherever you go, you actually can get that sort of constellation of services. So the wonderful early years people around here took that poverty tool and plugged it in as the orange pathway on what you're looking at here. So that's been just framed a little bit differently, but it's the comprehensive Toronto Early Years system, and the blue pathways for all children, the green pathway for children with special needs, and the orange pathway, as I mentioned. And then on the flip side of this, or at the website, you can see the other resources there. So a nice example, you might say, of integration of some of this into places that children go to and with their families. And of course, there's other wonderful documents people across the country have written, I'm sure, on office interventions for poverty. And here's an example of one here. Turning then to the speech and language tool, and our wonderful colleagues of expert in speech and language with public health sat down to develop something that docs could do in the office that would allow some action to happen before the number of months when they can actually, depending on your community, actually see the child. And so there's a 1 to 5 guideline here of things that can be done in the office. So there are some innovative things we can do to build capacity. The role of a lawyer working in a children's hospital is being appreciated, I think, increasingly in Canada. I think a number of children's hospitals in Canada now have a family legal health program, and the issues that get dealt with are family issues, immigration, refugee issues, education issues related to the child, income security, employment. Just been absolutely marvelous to have a lawyer working primarily with social work. That's the largest source of referrals, but certainly very, very accessible to pediatricians and nurses and everyone else. This paper from Mitch Blair in the UK has just come out talking about the role of pediatrician as knowledge broker, and he points out that we actually know more than we think about what improves children's health status, and he does note that it takes 17 years to get research findings into daily practice. I must say that was not my experience with infectious diseases, except maybe hand washing, but anyway, it is a wonderful point. And I guess the sharing of our literature, it does take a little bit of time, but sharing it with our friends in justice and education and so on does build and maintain intersectoral relationships. Finally, I just wanted to point out that, as we all know, we want to integrate with wonderful provincial and federal initiatives and make sure we're coherent and integrated with them, because they do address early learning, middle childhood and youth, roots of violence, and poverty reduction strategies that each region would have. So great to integrate with those, but it's terribly important that we always remember that. I think it's, sorry to sound a little passionate there, Dennis, but a participatory principle, because we have to ask ourselves, why have good programs? Because there's lots of good programs that have not worked, and it's amidst the realities that the communities can tell us about, the material deprivation and the stress. So we need to work with that. And the late great Leon Eisenberg has said all medicine is inescapably social, and we really do need a community-side manner. And finally, in closing, I just wanted to draw attention to the Paralympics. And maybe you're like me and you find that the Paralympics are as engaging and as any of the Olympic activities. People who you might think couldn't make it across a room are doing things that I can't even dream of. And that is what good social policy does, provides inclusion and opportunity. And it's not by chance, and it's not an end stage thing. Many, many things go into that working to state the obvious. So thanks very much.
All right, thank you, Lee. Or Dr. Ford-Jones. That was a great presentation, and this is my opportunity to remind the audience. There haven't been any questions come in yet, but please do type your questions in there. I know there was a ton of information that we just gave you there, but it was really, really fantastic. Lots of some great tools and stuff. So perhaps I'm quite sure some of the questions will be related to where people could find some of those tools that you popped up on the screen there, Dr. Ford-Jones. Is there an easy way to direct people to some of those links to the specific?
Yeah, you're going to post the slides, and every one of them, I believe, has the reference on them.
Yeah, that's probably because there was quite a few of them that I think people will be interested in. So that might be the best way. Is we'll get those up in a PDF form so people can have those specific references. All right, so we'll now move on to Dr. Bennett in Ottawa from the Children's Hospital of Eastern Ontario. Over to you, Dr. Bennett.
Well, good morning and bonjour, everyone. Can you see my slides because it's up on my computer?
Yeah, they look great.
You can? Oh, good. Okay, well, thank you, Lee, for that very passionate presentation and all those wonderful resources. Thank you to Dennis for your leadership in the series of webinars on social pediatrics, and merci to CAFC for hosting us today. I'm sure you've seen this before, but never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has, says Margaret Mead. And I'd like to change that word citizen for pediatricians and child and youth health professionals for today's webinar. Health advocacy is a needed competency for all physicians in all specialties, as enshrined in our Royal College of CanMed, and the health advocate role has just been updated. We have a responsibility to advocate for, and I would emphasize with, children and youth for their best possible health. I'm aware that I'm talking to the converted for most of you on this presentation, but because children may not have a voice of their own, because youth do but may not be listened to, because they cannot vote, because they rarely have access to the courts, because they are not members of trade unions or professional associations, because they do not have powerful lobbies acting on their behalf to counter the well-resourced and sophisticated corporate lobbies, and because public policy affects children's health. Now to the child protection side of things, the Battered Child Syndrome by Henry Kemp was a landmark paper published in 1962 and was instrumental in raising society's awareness of the existence of child physical abuse and the subsequent development of the child protection system we now know in Canada, with laws mandating reporting of suspected child maltreatment and child welfare agencies receiving these reports, investigating them, and being the legal authority to protect children. We know of other kinds of abuse: sexual abuse, psychological, emotional abuse, neglect, exposure to domestic violence. And more recently, there's more awareness, I think, of the cultural practices, be it physical punishment of children, female genital mutilation cutting, the prostitution of children, child pornography, better termed in my mind as child abuse images, child trafficking for the purposes of exploitation, child labor, forced early marriage. And now children and youth inhabit a new space, cyberspace. Child maltreatment is common. The Canadian Incidence Study of reported child abuse and neglect are our national statistics. In 2008, 1.6% of children in Canada had substantiated child maltreatment and confirmed risk. I would suggest that this is the tip of the iceberg, as child maltreatment may not be identified, and even if it is, may not be reported. And this is a breakdown of the types of abuse. Note that a third of the reports offer neglect, and another third exposure to intimate partner violence. I would suggest there's gross underreporting at 3% for sexual abuse. The impact of child maltreatment can be significant. There may be immediate effects and lasting effects into adulthood and affecting the next generation. The impact can be on the physical, mental, and social aspects of the individual child's health and development. And there is the economic impact, something that governments would surely be interested in. For the single year 2008, the US Center for Disease Control estimated that the lifetime cost of child maltreatment was $124 billion US. We now have an emerging science of child development with the convergence of evidence from neurobiology, epidemiology, and epigenetics. And I'll just mention three main areas of studies: the adverse childhood experience study, stress studies, and epigenetics. And the challenge is to put this new evidence into programs and policies that affect young children, and the Canadian Paediatrics Society is taking a leadership through their early years task force, amongst others. The first study I'll mention is the Adverse Childhood Experience Study, which is an ongoing collaboration between the CDC and Kaiser Permanente in San Diego. The study has more than 17,000 participants who presented to a preventative medicine center for comprehensive medical screening, and analyzed the relationship between childhood trauma, ACEs, to later health and behavioral outcomes. And exposure to one category of, and I'll show you the categories momentarily, is 1 point, and the points add up to the ACE score. So the categories assess childhood exposure to multiple types of abuse, neglect, and serious household dysfunction. The results show that compared to persons with an ACE score of 0, those with a score of 4 or more are twice as likely to become smokers, 12 times more likely to attempt suicide, 7 times more likely to abuse alcohol, and 10 times more likely to inject street drugs. All of these behaviors might be seen as short-term soothing for the individual who has experienced early childhood experiences. But clearly there are secondary problems arising from these risk behaviors. The conclusions from the ACE study is that the number of categories of ACE exposures showed a graded relationship to the presence of adult diseases, including cardiovascular disease, hypertension, hyperlipidemia, obesity, asthma, skeletal surveys, liver disease, and infection, including risk factors for several of the leading causes of death in adults. The economic costs are huge, quite apart from the suffering. In 2012, the American Academy of Pediatrics produced a policy statement and a technical report on toxic stress, and this is really the link between the ACEs and the long-term health outcomes. And to explain, there are 3 levels of stress. You might say there's positive stress, where there's a brief increase in heart rate with mild elevation in stress hormone levels. Tolerable stress with serious temporary stress responses buffered by supportive relationships. And toxic stress, and you might imagine in the context of the 10 ACEs previously noted, or for extreme poverty situations, the prolonged activation of stress response systems in the absence of protective relationships. When we look at brain development, relationships are the active ingredients of environmental influence on early brain development. An excessive repeated stress causes release of chemicals that impair cell growth and interfere with the formation of healthy neural circuits. In contrast, nurturing responsive individualized interactions build healthy brain architecture that provides strong foundation for all future learning, behavior, and health. The third important piece of scientific evidence is from the field of epigenetics, the study of environmental factors that change where the DNA of genes will be expressed without altering the DNA sequence itself, factors that change the likelihood that a genetic book will be read. The genes are listening to the environment. We can no longer ask, is it because of nature or nurture, because it's both. Not only do we have a scientific basis for advocating for the prevention of child maltreatment and promoting child well-being, but we also have a legal and moral mandate when we view child maltreatment as a human rights violation. The United Nations Convention on the Rights of the Child was adopted by the UN General Assembly on November 20th, 1989. There have been 193 ratifications, all the countries in the world except for the US and Somalia. Ratification means that under international law, governments have to take all necessary measures to implement the convention in their country. The convention defines the full range of children's needs and provides a practical framework for addressing these needs in an integrated and holistic way. The convention contains 54 articles and provides a universal set of standards with which to measure and improve the care and treatment of children. The convention challenges a traditional approach to children which saw them as passive objects of charity and instead acknowledges them as both capable and entitled to active participation as subjects in decisions that affect them. The Convention has 4 guiding principles: the right to life, survival and development, for non-discrimination where the Convention applies to all children everywhere less than 18, that the best interests of the child should take priority in any matters affecting them, and the 4th being respect for the child's view. The Convention views the child holistically, living in relationships within the family community and larger society protected by the provisions of the Convention. And UNICEF describes the child protective environment in 8 sectors: government commitment to fulfilling protection rights, legislation and enforcement, attitudes, traditions, customs, behavior and practices, open discussion including engagement of media and civil society, children's life skills, knowledge and participation, capacity of those in contact with children, basic and targeted services, and monitoring and oversight. And in relation to this latter accountability mechanism, we have the UN Committee on the Rights of the Child Monitoring Committee, which monitors how well states, that means governments who've ratified, are meeting their obligations under the Convention. The committee facilitates state party implementation of the Convention, and governments must report initially 2 years after joining and then every 5 years thereafter. There are parallel alternative reports from non-government organizations, UN agencies, other organizations, academic institutions, and indeed children themselves. There are 18 members with a 4-year mandate, and the committee publishes its concerns and recommendations in concluding observations. So here we have the alternative report to the Convention, which was produced by the Coalition on the Rights of the Child when Canada presented their 4th report to the committee in September 2012. And I would suggest that our participants do take a peek at this. It's a really excellent read on the status of children in Canada today. The UN Committee on the Rights of the Child gave their concluding observations for Canada's review in October 2012. And actually the Canadian government delegation, I was present at the review, did state that the UN Committee that Canada is fully committed to protecting children's rights. But the committee gave them a hard time at this review, saying that they expected more for children in one of the world's wealthiest nations. The Canadian Coalition synthesized the concluding observations and recommendations into 10 steps for children in Canada. And it essentially gives us a roadmap, a very useful roadmap actually, in an action plan. And Dennis, I should say that this puts the child health and well-being on the federal agenda. The 10 steps include collect accurate data, analyze and publicly report on the situation of children. Our government had a difficulty providing basic information about how children were doing in Canada, and the recommendation was for a national comprehensive data collection system. The second was create a consistent framework for policies that affect children, with the recognition that policies for children across Canada are piecemeal in a federal system and inconsistent, and though many children do well, many fall through the cracks. The Convention needs to be incorporated into Canadian law. Number 3, implement a national strategy to prevent all forms of violence against children. Allocate resources and ensure there is monitoring. Piecemeal initiatives have limited impact. $5 million was recently allocated to prevent hockey violence after concussions made headlines. Bullying receives attention whenever there is another suicide. Millions are spent on policing internet sexual exploitation, but little is spent on prevention. Section 43 of the Criminal Code continues to condone the physical punishment of children, when 35 countries across the world have abolished violence against children in all settings, including the home. Take immediate action on specific policy changes identified in the review, and I'll just name a few. To establish annual targets to reduce child poverty, ensure equal access to health care and education for all children in care, ensure disabled children are not forced into segregated schooling, ensure the best interests of the child principle in all cases where children are involved in immigration and refugee hearing, monitor the use of psychotropic drugs and psychostimulants on children to prevent overuse, and I have to say many more. I don't have the time to give you any more at this point. Protect all children from underage marriage was also discussed. Establish a national advocate for children, a federal ombudsman to represent children at the federal level and ensure comprehensive and systematic monitoring of all children's rights. Ensure equitable treatment for Indigenous children and all other minority groups, and for immediate steps to ensure that Aboriginal children have full access to all services without discrimination. Consider the best interests of the child and views of the child in all decision-making affecting them. Inform children about their rights and train adults who work with them. Evidence from the Rights Respecting Schools project in England has shown that effective rights education can improve school achievement, reduce bullying, make schools safer, and develop skills for living. Provide access to affordable quality childcare. $100 per month per child is not adequate for families. Childcare in Quebec was held up as a good practice before the UN Committee, but in Canada it remains the exception rather than the rule. And 10, make the youth criminal justice system consistent with the Convention. Concerns were raised regarding increased use of detention, publication of names of young people, and less use of restorative justice. The recommendation was made for a full, transparent child's right impact to be done on Bill C-10, with amendments made to comply with the Convention. In closing, I would like to recognize our dear friend and colleague, Dr. Clyde Hertzman, who passed away suddenly last year. He's seen here in Tanzania in this photograph in the blue shirt with his research collaborator, Dr. Ziba Vagri from HELP, the Human Early Learning Partnership at UBC. HELP, under Clyde's leadership, was the knowledge hub for Michael Marmot's World Health Organization Commission on Social Determinants of Health, and the Commission identified early childhood development as one of the most potent social determinants of health. Clyde and Ziba subsequently developed the Early Childhood Rights Indicators for the UN Convention on the Rights Committee, and they successfully piloted these in Tanzania and Chile, and there are plans for implementation in Canada. The UN Committee have now requested the assistance of the Global Reference Group for Accountability to Child Wellbeing and Child Rights, led by the International Institute of Child Rights and Development and HELP in BC, to develop a full set of indicators for the Convention using Clyde and Ziba's model. And here we have the Convention symbolized as a tree with its provisions represented as branches and the soil and roots the accountability mechanisms through the Monitoring Committee. The Convention covers all children, as I've mentioned, from 0 to 18 years of age. The Early Childhood Rights Indicators, that was based on General Comment 7 for early childhood, covers all the provisions in the Convention for the ages 0 to 8. And we are now in the early stages of developing the indicators for the rest of the Convention. It's going to be a lifetime's task, but we're presently working on the indicators for child protection in the early days. Global Child represents the vision for all children everywhere to be protected by all aspects of the UN Convention on the Rights of the Child, to respect their dignity, and for them to reach the best possible physical, mental, social, moral, and spiritual health and well-being, development, and personal security, and to lead a life worth living. Thank you.
Thank you, Dr. Bennett. Great presentation again. Just lots of great information. And we're going to be moving on to Dr. Jean Clinton in a second. But Dr. Danneman, you had a question about the United Kingdom's experience with a national child commissioner. Many in the CAFC audience are familiar with Sir Al Ainsley Green. And you sort of had a question about what lessons could be learned in setting up such an office. Maybe you could just raise that for the audience.
You want me to raise it, or do you want Sue to answer the question?
Go ahead. If there's any other, or we could go right to Sue, or if there's more to the question that you wanted to sort of ask to frame.
Well, there was a big fanfare in setting up Al Ainsley Green as the UK Child Commissioner, and he was very fastidious in going into a variety of different environments to learn a lot about what was going on in the UK. And I guess one government was voted out and another government came in, and that was almost the end of it. And so from having some effect, it sort of disappeared. And what we really want is something that had some longevity and resilience. And if anybody has any comments, I would like to hear from them.
I could just say just a couple of brief comments that Al, in a not-so-private conversation, did say that during his time as the UK Commissioner was public enemy number one. The media onslaughts against him was just absolutely amazing. There have been a couple of private members' bills brought forward by our MP, who was a former astronaut, which I thought was very symbolic, but it didn't get too far with the present government.
It was Mark Garneau that tried really hard about a year and a half ago, yes, through a member's bill.
Right.
Mm.
The problem at the time is he was running for leadership in the Liberal Party, so they weren't exactly going to vote for such a private member's bill. Mm. So we're going to keep going back and see if we can get any traction on it.
Doug and everyone at Tulane, just a quick comment. I think just to the Children's Commissioner point, maybe a personal view and something that I certainly have heard many say. Dennis, your point of the timing of Mark Garneau's members bill, the timing was not ideal for sure. But I don't think we should ever, we as a greater community, I don't think we should ever let that off the table, and maybe be a bit more strategic in striking when the timing is better, or, as good as it can be kind of thing. Sort of to look at what else is hot as far as, the public and media are concerned, and then strike. But always be ready with the argument and the evidence of why this is so important.
And particularly in a federal state where things are just siphoned off.
I agree.
Even the definition of the age of a child, even to that extent, we're talking about different populations.
Exactly.
So the other comment I would make is that sometimes with these offices that are put in place, the government of the day is able to say it's under study, it's being evaluated, and then nothing gets done about it. So there needs to be a driving force that makes sure that there's activity that's going on.
It's Jean here. One of the things I would like to know is how effective is a Children's Commissioner. So if we're thinking about how do we create a federal as well as a national and provincial child well-being plus system, is having a commissioner, has it been shown to be an effective strategy to bring people together and get action? I know when I spoke with Sir Ainsley Green, he talked about all the good work that had been accomplished was tossed out or was certainly undermined when the new government came in. And it worries me a bit about focusing on one aspect, which people can then have arguments about if we're not at the same time building the other parts of the system that can move for structural advance. So it doesn't matter what government does, we've moved the field forward for children.
Yeah.
So the other aspect of the Child Commissioner that needs to be taken into account is that child health doesn't occur in a vacuum, and if you're going to choose one aspect that is most likely to impact on child health is maternal health. So the two have to be very much allied to each other.
Maternal health.
Yes.
And
Did you
you
say
know what?
absolutely, Dennis?
It's interesting. One more quick comment. Maybe, Dennis, it's Elaine again. Maybe that's a strategy that we need to consider is that maternal and child commissioner. Just anyway, you just sort of struck a chord. So just food for thought, future food for thought.
Just to say, those discussions I know I've been involved in the past, and if we're looking at children don't come alone. They do come with their families and their mothers, but they can be sort of conflicts of which rights can be overriding.
Point well taken, Sue. Yeah.
All right. Well, looking at the clock and looking at that we do have Dr. Clinton's slides up on the screen, let's hand the virtual podium down to Hamilton and McMaster Children's Hospital in McMaster University, where Dr. Jean Clinton is. Over to you, Dr. Clinton.
Great, thanks very much. And I'm just happy to be a participant and listen to all these fantastic presentations. So I'm going to focus on something a little bit different than Lee and Sue, but riff off of some of the thoughts that they've had, and first of all start by echoing what Sue said in terms of a few individuals making tremendous change and dedicating to Dr. Dan Offord and to Clyde Hertzman. And I bring Dan as he was the first one to look at the Ontario Child Health Survey in 1984 that identified the huge issues that we have in children's mental health, with children, 25% of our children having significant mental health difficulties. And the first to recognize that where you go up has a massive impact on your development and your mental health, and in multiple domains. Clyde brought to the story many things, but they were both fascinated by the question, why is it that some people get sick and others do not? And Clyde really taught us most about two aspects I would share today, and one is the gradients in health, that being that when you look at health outcomes and education and a multitude of other outcomes, the poor children are worse off than the well-to-do children. But the thing that we have to keep in mind is that there is no cutoff point above which all children do well. And that's to say that there is a gradient. So we've got the greatest percentage of children with difficulties living in poverty, but the greatest number are actually living in the middle class and higher when you look at things such as vulnerability arriving at school. Recent Sutton Trust report that has just come out talks about 40% of children having very significant attachment difficulties, and this is not isolated just to kids who are living in the lowest SES group. So as Sue has mentioned, the social determinants of health are becoming more and more a part of the dialogue as we think about child well-being and resilience of necessity. And as Sue mentioned, Clyde led the international collaboration that wrote Chapter 5 of the Sir Michael Marmot report, and it stated really that social policies are what are killing people on such a very, very large scale. And Clyde and Dan both in their work wondered, why is it that some people are healthy and others are not? And after much study, recognized that what happens in the very earliest years makes a huge difference. The concept of biological embedding that I'll mention is one that was coined by Clyde to talk about how is it that the conditions that Lee has so beautifully described and Sue has described, how is it that they actually get under the skin and leave a biological signature literally on the DNA, the epigenetic effect, as Sue's pointed out. And so the reality is that in order for us in pediatric practice, those of us who are interested in the population health of our communities and of our children, it's essential that we begin to move more and more upstream causes of the health difficulties. This is a slide created by for the WHO report. Again, it's interesting, we didn't all coordinate, but we're all using the ecological model here that you see, and reading chapter 5 of the Equity from the Start indicates that there are so many different ways and aspects that influence the child throughout. The individual characteristics of the child, the genetics, the biology has a major influence on how that child will integrate, interact, intersect with the family, the quality of the caregiving that the family can provide because of their own attachment issues, because of their own support systems, because of their view of parenting, because of the pressures that they have to meet ends meet. All of that will influence the development of the child and their expression genetically. Residential area, is it safe? Is it laden with syringes? Is it dangerous? And other such characteristics make a huge difference and influence the development of the child. Clyde all of these various influences have both a direct effect, interactional effect, but also can have a cumulative effect. When we look at local influences, we can look at a place like Hamilton to see, are there differences? Do we see expressions of this? Do we see expressions of these different determinants of health locally? You know, the differences in life expectancy between Botswana and Japan, we can kind of understand. But when we look in Hamilton, we see that there are the same gradients in terms of high school dropout rate. The deep red that you see here is the worst 20% of children, and moving out gradually out to the greens, you see the better off neighbourhoods when you look at the children who are living in poverty. So what we see is that these social determinants of health are alive and well and living not far away but right beside us. Then when we look at, so we've seen some of the child indicators, and then we look to see, well, what is there any link of these, as Kaiser Permanente has been doing, to adult health. And what we see the cardiovascular related emergency room visits, and put them on the same map that we see for our childhood indicators. So this is a slide from Nora Louroux, and it really is, I'm very frequently on the radio and was just visiting another province, and was asked, you know, whose role is it anyway, really? You know, that mum has her kid, she has to look after her. And so here we see families or societies that we have a mother duck doing what a mother duck does, and comes across a social condition over which she has no control. And what happens? We see bye-bye ducklings. So clearly we have to be creating the culture and the climate that says how our children do well or not is all of our responsibility. And in fact, when I was in Washington, one of the vice presidents of the Federal Reserve Bank said, you know, you don't even have to like children. When our children do well, we all do well. So focusing then on when are the periods that make huge, huge differences in terms of return on investment. And believe me, I'm a child and adolescent psychiatrist, so I'm very, very much involved in children beyond the age of 6. But from a straight economics, from a straight when is the biggest time when we can modify the environment for brain change, this slide from Dr. Mustard shows us that the periods of the brain as we now know is much more malleable, much more brain plasticity, that continues for a longer period of time than we knew, that the greatest period of vulnerability, but also excellence in plasticity happens way before before children even arrive at school. So if we're talking about leveling the playing field, if we're talking about all kids coming to school ready and eager to learn, we absolutely need to be looking at what happens before they arrive at school, when the brain is most plastic. And to keep in mind that poverty can make very, very big differences. Lee's work is showing us so strongly. But we also have a ton of stuff that we can learn from people living in poverty. How it is that they are managing with the tremendous stressors that they do. A recent study, repeat of the famous 30 million word gap study, showed that within families living in poverty, the range of words that a child heard in a 1-hour period, one mum, there were 67 words face-to-face that child heard. That's less than a 60-second commercial. But another equally poor mum, the child heard 1,200 words, thousands of words per hour. So the key message in this is that parenting, supports to parenting, giving parents the freedom to do the best for their child makes a big difference. And it is this most intimate relationship, the serve and return, that makes the big difference. So what is it, the big difference? What is it that we are finding, we being the big science guys, I just steal their stuff, but what the science is showing us is that the conditions that children are incubated in, as well as they come out into, affects the expression of the DNA. And again, we've heard a little on this from Sue. But this is one of Clyde's favourite slides. These are the same, identical genetically butterflies. The one was incubated, the yellow one was incubated in the wet season, identical genetically, the blue one incubated in the dry season. So what was it? There was some trigger from the environment that talked to the DNA. It talked to the DNA to say, be prepared for a different climate out there. In the wet season, if you don't want to be gobbled up, there were parts of the DNA that were either methylated to make this color, or the chromosomal, the histones got acetylated. The environment put on a signature or a tag to activate or silence the DNA. So what Clyde and his colleagues, looking at longitudinal studies over a number of different continents, have now definitive data that shows that problems happening early in life leave a mark. They leave a genetic signature mark, and it affects what you see: second decade, school failure, teen pregnancy, criminality; third and fourth decade, obesity, elevated blood pressure, and depression. On and on you see here. What's ironic is we have primary care, we have physicians looking extremely seriously at what they can do about chronic disease management. We have public health looking at chronic disease management, and not nearly enough on what are the conditions that led to the chronic disease in the first place. It's not the life choices. One of the biggest areas, as Sue has said, has been looking at the impact of toxic stress and the brain. We know, as Sue has pointed out, that this is a picture of when Foo Fighters or something, a group was singing, just to get you the idea, that there were 85,000 reports of child maltreatment in 2008. 85,000 reports of substantiated child maltreatment. In a single year, we may have 1,000 incidents of childhood cancer. I am pointing out here that the difference in how we perceive the social and emotional development of children, the safety of children in this domain, relative to the hugely important but disproportionate, I would have to suggest, amount of focus we have on physical illness, really must be addressed. Why? Because we know that the long-term costs of our 85,000 children with child maltreatment issues are going to be a long, long legacy that we are going to be having to deal with in chronic disease, in school failure. We're going to have to be looking at increased jail cells rather than less. So as we talk about these things, it's very obvious that we are just at the tip of the iceberg, and in fact, our kids are very much giving us a signal as we look at the UN Convention on the Rights of the Child, as we look at the latest report from the UN, where we're 17 out of 29, we have to realize that we have a similar situation to these boiling frogs. Now, no offense to any animal, but this was a favorite of Clyde's, and he spoke about how if you put a frog in boiling water, it jumps out immediately. But if you put a frog in cold water and very slowly increase the temperature, then the frog gets boiled. We have a situation with our UN report and other statistics, as I've shown you in longitudinal data, that our children, we are doing a massive, massive social experiment, and already we know what the answer is. Now, if we had little frogs that were numerate, they could stick a thermometer in and say, oh, sacre bleu, I need to jump out. But as we know, our kids are not voiced, they don't have they don't vote, and too often we have a society that has children's well-being as an afterthought. We have, in Ontario, introduced an enhanced 18-month well-baby visit as part of the strategy to get people to think about development, connecting to early years resources, attachment, so many more activation of thinking about the community raises the child. We know from the EDI, the Early Development Instrument, which kindergarten teachers fill out, that over 30% of kids are arriving vulnerable. Well, that's reflecting what has happened before. Can we intervene and look at things earlier to get our temperature reading? How are our 18-month-olds doing? But wouldn't it be wonderful if we could take it earlier? Yes, I need to, so I'm going to stop here because I need to leave the room that I'm in. So over to you. Doug, can you take over as I move out?
Had myself muted. Sorry about that. So thanks for the presentation.
Yes, sorry about that. I just need to leave this room.
Okay, no, that's all right. So we did, again, I think we've, another great presentation packed with information. I think we've set our usually inquisitive and audience on its ear, because we don't have any questions from the audience. I think they're still in the process of processing. But Dr. Daneman, we did have another question from you about while no one argues with early child development as a pivotal time, does this potentially take the limelight away from the good that could be achieved at all stages of the development cycle?
My question is probably rhetorical, because I think we know some of the answers. There's clearly a very important window of opportunity that takes place during all of pregnancy and into the first years of life, with early childhood development, stimulating everything that's been talked about. But there are a good number of children who come to Canada from other places in the world where they've been disadvantaged during this period of time and left to their own, they will probably have significant disadvantages as adults. And so I think we need to look at the data that suggests that you can have improvements in performance even when no good has been done early on in life. So one should never give up at any point in time. One should keep encouraging, stimulating, trying to do what molding can be done. It does have some significant improvement effects. Lee, you might want to comment on that.
Well, thanks, Dennis. Yes, I actually, when I first heard about coming from infectious diseases, the wonderful work on experience-based brain development, and I ran that past colleagues in the community who I trusted, and they know well enough that they gave me honest answers. They said, "Oh, you mean the bad brain theory?" And it really is an example of just how our exciting work is perceived if we don't discuss it with people who are living these realities. Because exactly as you say, we want to be able to help people all along the life trajectory, and indeed cases like the Olympic show jumper have shown us, and many other examples, we can help children in middle childhood and youth. And it's really pretty devastating when people look back on their early years and think, well, I didn't do that for my child, so it's looking pretty grim now. It's the last thing we'd want to do.
Okay, and so can I just jump in here as well? Sorry about that. I was scooping a room in there. This, I think, is a very, very key issue that we need to find the right language for, because one, there's no doubt that there are modifications to what can happen later. Absolutely. The idea here is what can we do to build the best structure that we can, but the other then is to say that we can improve later. One of the things, I'm in the process of writing a 0 to 6 mental health brief. And this same kind of issue about, if you spend on the early years, doesn't it mean that you're not going to be spending as much on the adolescents who are cutting and all of those, really acute things. And it's well, should we be paying all this money for this 2-year-old with leukemia? It's not going to be treating the 12-year-old. So it's a fascinating area that we have. I think they are two separate issues. It is not deterministic. We have to be building properly, but there is a very large bias that I'm finding in terms of addressing the needs of 0 to 6-year-olds, which is, I would love to have the wisdom of this group to see how one addresses it.
So it would be nice if some of the people in the audience, we're down a few people, but there's still a large number of attendees would sort of pass comments. We must have said something that strikes a chord, or something that sort of you'd like to argue a point with. So send in your questions or comments. They're really very welcome. So the other thing that sometimes gets the ear of the powers that be is the idea of the worry about what the child will become, because when they look at the bucket of money in the available for child health, it's less than 5% of the total for adult health, and so the elderly are getting much more attention, which is just as well, because some of us are getting to that stage. But it's important to try to improve the health of the adult population by maintaining the health and development of the pediatric childhood population, and that doesn't get as much mileage as we could.
All right, we did have a question come in from Lee, and she says, and a comment. She says, "Thank you and the other speakers for a fabulous presentation." But she goes on to ask a specific question for Dr. Bennett, and she says, "Can you please give us more detail on the fact that the U.S. and Somalia are the only two countries not to have ratified the CRC, and maybe any underpinnings that you might be aware of for that reason?"
Yes, I should say they've both signed, so they have agreed in principle of the convention, but they haven't ratified. And one could say for Somalia, they don't have a government. That would be one reason. They don't have a signature body to ratify it, even though they've signed, but that's the story. And it used to be said in the previous U.S. government that it was because Somalia didn't have a government, and it was because the U.S. did have a government that they haven't ratified. But under Obama, there were great hopes that the U.S. Were going to ratify, and there have been discussions. Certainly Hillary Clinton was very much promoting that, but he's had a lot to deal with, I must say, in these 2 terms. Hasn't been popular, and there's a very vocal, well, there are a couple of issues. There's a very vocal right wing who would be fearful of children, interpreting the convention of children taking over the family, that children's rights under this convention would trump parental rights, and certainly this extreme conservatives would be having a real problem not being allowed to physically discipline their children, for example. So the extreme religious right being vocal. The other issue, and I'm not a lawyer, but I do understand that if they have to get 75% of the states, the individual states, come on board to ratify it, that's one issue. But it seems because of the U.S. Constitution, and I'm not too clear about it, but if it was ratified, it would become primary, such that the U.S. Government, in a more powerful legislation than it would have been in other countries because of the U.S. Constitution. That's what I'm hearing. But we remain optimistic because there are discussions. There's a very strong movement for the ratification by the U.S. and certainly a good number of pediatricians leading that. I should just mention Jeff Goldhagen. He was the lead on an American Academy of Pediatrics policy statement on health equity and child rights. It's a great read and a great document. And he is leading the development of an online, well, it's going to be a text-based curriculum in the future on community and societal pediatrics. Not calling it social, but societal, in some ways raising the bar, talking about child rights as being primary, social justice, social accountability, molding medical ethics with right language, because it seems to be right language much more used in European within European pediatric circles than it is in North America, where we talk about medical ethics a little bit more. And so Jeff Goldhagen at the University of Florida is one of the leaders in that group.
All right, thank you.
Just a quick comment here, if I may, on something new on children's rights and business principles that I think was just launched this month, and Sue or someone may know more about it, but it's just by UNICEF and Save the Children's. There's a children's rights and business principles, comprehensive set of principles to guide actions in the workplace, marketplace, and community. So furthering to what Sue's been presenting to with us, it's and along those same lines, maybe it's another lever we can use to engage more people in this discussion. I don't think they're looking for a certification process like fair trade coffee or dolphin-friendly tuna for a company or a marketplace, but it is a nice set, looked like a nice set of principles.
And where that comes from, the UN committee have, they take up as a group particular issues or particular articles that are challenging for their work, and they run a series of general comments. There are 17 of them at this point, and I was very much involved with the right to freedom from violence against children. That was General Comment 13, but there have been 4 in the last year, one of which has been industry and, well, business and children. The other 3 have been the right to play, best interests, and the right to health. And all of those documents you can access on the website, and they're fabulous in plain language, maybe sort of 15, 20-page documents, wonderful advocacy tools. They're usually well-researched, and usually the committee draft those out to international experts, and great advocacy resources.
All right. Thank you.
So while
So it's Jean here. I have a question for the group. Sorry, Jean here. Can I ask a question?
Go ahead. Yeah.
Yeah, so one of my questions that really puzzles me is the Innocenti report that came out recently, and the one that came out a couple of years ago, really are pointing to us as a nation doing very, very poorly when it comes to our children. You know, we're 17th out of 29, and you know, this is us talking about our teenage children and other components. And I'd really love to understand how it is that something as huge as 27 out of 29 childhood obesity really doesn't capture the public's eye. That doesn't capture the government's eye. Even Kelly Leach's report, Reaching for the Top, was essentially groveling from the bottom because we did so poorly. Why is it, and what can we do when we do monitor, when we do have data? We don't seem to be able to mobilize.
So there are a couple of things, if I can just pass a couple of comments. Some of the data are just downright incorrect on the UNICEF report. For example, infant mortality is one of the worst in the world. It has been debunked by a very nice article that appeared from Joseph and others in the British Medical Journal a couple of years ago, which showed that we report births under 500 grams and under 1,000 grams in Canada and the US about 10 times as often as they do in many of the Scandinavian countries. They report that as a stillbirth. That child is not born, because they do not resuscitate those very small children. When you take those kids out of the mix, there's no significant difference between any of the low infant mortality countries, Canada and the US. There are a couple of higher ones that remain high, but Canada and the US fall onto exactly the same line. And that's in keeping with the low birth weight data as well, in which we look better. So I think some people are very willing to say, we don't know where these data come from that UNICEF gets, therefore let's ignore them. So we have to make sure that we have absolutely the right data. The data on childhood obesity, I believe, is good, is accurate, not good in any way, shape, or form. And I think we need to act on that. But again, this is one of those things where prevention doesn't get the eye or ear of the government as much as intervention and treatment of disease. So I think first is getting it accurate, and the other part is, for example, Canada scores near the top on the performance of international student achievement, the PISA scores, but it scores lower down in other aspects of education achievement. So can you believe one and not the other? So people are willing to cherry pick and do what they prefer. So I think we need to get it accurate, and then we need to certainly deal with it. Can I ask Sue a question?
Hello?
Sue, can I ask you a question?
You can.
So we've sort of looked at, in terms of child protection, is protecting the child from the effects of child abuse, neglect, etc., etc. What about the child who has gotten to the stage of being frankly neglected, abused, etc., and we've taken into the system, and the system seems to fail them all too often, or at least there are a lot of cases that make it onto the front pages of the newspapers. Where are we failing in our system?
Yes, and you've just had your case in Toronto, right? James Baldwin, the inquest and the recommendations, and there's over 100 inquests, and then everything changes. I'm always thinking that you wait for the inquest to get the changes, which then get implemented. You know, my perspective after all these years has been, because I'm director of the Child and Youth Protection Program here, is that it's understood that it's protection from child abuse, maltreatment, and all the forms that your imagination can't even imagine. And I've really come at this stage of my career to understand that we have to be protecting and promoting the children's rights. It's not just about measuring the bad stuff after it's happened. We have to be preventing it. Primary prevention. We have to be recognizing before it happens and supporting families. In the present system, you know, there's the sense, and the Children's Aid Societies are doing magnificent jobs under the resources and expertise they've got, but they are responsible, as I said at the beginning of my presentation, for the child protection system. Society, every person is involved in this in protecting children. They need a wraparound at all, you know, the circles of care, and they're not sort of concentric circles. They're interacting in all different levels. And I was just picking up, particularly in my presentation, about the government responsibility, which the convention really squeezes, and with the indicator development for the monitoring being even tighter, that I feel that with the Canadian government, for example, who knew the statistics, if we had clear, understandable statistics of what the reality is for the kids, you know, I think civil society would get it, and there'd be a swell of concern. So in a simple language, I don't think we can allow to say our child welfare system is responsible for child protection. It's after the fact. We need to be moving proactively in as I say, the holistic child, and we need to be developing. We have the wonderful OECD studies, but when we look at the measurement of what the indicators for child well-being are, we're good at measuring the bad stuff, but you know, we should be developing our indicators for what is it for what we want for our kids in well-being, looking at the resilience, the strength, the asset base. We have to become more, I mean, we have to deal in the tertiary care centers without a doubt, you know, the tertiary care issues, but the promotion and universal promotion involving kids themselves. We need, you know, there's an untapped potential in kids themselves when we listen to them.
Dennis, it's Lee here. I wonder if it's also worth looking further as to what the parents need. What do the families need? And I've heard esteemed speakers in Canada say that the 4 things people need are purposeful activities, some social support, a place to call home, and enough money to live off of. And I wonder if parents actually had those things, if that would make things better for kids, building on what Sue is saying.
Well, certainly the income inequality has been shown to be related to poorer outcomes and poorer UNICEF outcomes. And Canada, as we talked last week, flat in the middle of those income inequality ratings. So that doesn't help us one bit. But, you know, as I said last week, 2 weeks ago, happiness increases to $75,000 family income and doesn't increase above that, it plateaus. So a better distribution of wealth would be important, as occurs much more likely in the Scandinavian countries.
We did have a question come in from the audience from Margot, and she's asking, in terms of understanding how big a part that social and societal factors have in affecting health outcomes, how can we help shift people's minds and hearts away from blaming only the family to really understanding the problem? Like, how can we help the general public and the average person sort of change their hearts and minds?
That's a very, very good question. As part of the Ministry of Health of the Province of Ontario's strategy on reducing childhood obesity by 20% over the next 5 years, there were a number of people who basically felt that way. Childhood obesity is it's the malignant disease of gluttony and sloth, and that was it, period, the end. And they don't realize that it can't be that. There has to be much more to it in the way it's occurred in different parts of society. And it took a while to understand that there are many different things that have interacted in that way. So it's a story that we have to tell repeatedly. As soon as we blame parents for everything, then they withdraw and they get out of the system, particularly those who are not well treated in the system.
Anyone else have a comment on that?
Well, I think Clyde used to say neuroscience has caught up with the social epidemiology, because I guess the social epidemiologists have nailed this for years, and now we as physicians have this powerful biologic evidence with the cracking of the human genome and the explosion of molecular biology, that what goes on in the social context literally shapes, as Jane said, the epigenetics, the function of genes, and shapes the child. So I guess just sustained unprecedented activism on this point, and motivating every inspired and inspiring person, I guess, is part of it. But others may have much clearer thoughts.
No, I think we're very clear thoughts there, Lee. One of the things that Clyde and Neil Halfon both talk about is the fact that we've created a system where people have to fail, from the old poor laws, that people have to fail in order to receive a handout or a hand up. And the to try and work on the paradigm shift that to create health requires all of us. It's not individual choices, it's having the parents having access to supports, it's having high quality care for the child so the parent can go back to work, to bring in the dollars to sustain the economy, to have provinces or to have cities that say we need play spaces and creative places for kids to play so that they can develop their creativity. It means that we need provincial governments who say, yes, the allocation of these things to the municipalities makes sense, because at the heart of the matter we're thinking about what does this decision have to impact the next 7 generations. So it's a paradigm shift to saying all kids are our kids, and it literally does take all of us to raise healthy kids, without us sounding too welfare, socialist, whatever. The reality is, as the economists are saying, you don't even have to like kids. It takes all of us to raise healthy kids, and when they're healthy, then we all do well.
So we're going to end at this point in time, and I wanted to thank the 3 speakers today, passion and provocation. So I think this is important. Every one of us takes something that we had only thought about a little bit before, not at all, home with us, and thank you very much. And I'd like to welcome everybody in a few weeks' time, May the 7th, to the last one on vulnerable populations, because Canada differs very much from, say, the Scandinavian countries by its very large geography, very sparse population in some areas, its immigrant and refugee populations, certainly the First Nations populations, and we need to talk about that. And then we need to talk about who needs to be brought into the learning circle of what to do about it, because when we talk to pediatricians, we're preaching to the converted, but there are many other groups that are very important, in fact, more important than pediatricians in parts of the spectrum. So thank you, everybody, and back to Doug, and he will close.
Perfect way to wrap this up. Thank you, Dr. Danneman, and thank you to Drs. Lee Ford-Jones, Dr. Bennett, and Dr. Clinton. Fantastic presentation. As I mentioned at the beginning, we do record these, and the audio-visual recording and the PowerPoint presentations in PDF form will be up on the Knowledge Exchange Network in the next couple of days. And as Dr. Danneman mentioned, May 7th will be the date of the 3rd installment of this 3-part series on social pediatrics. So we hope all of you will be able to join us at that time, or at any of our other CAFC Presents webinars, which we typically do on Wednesdays at 11 a.m. Eastern Time. And you can always go to the CAFC.org website and just look for the CAFC Presents section, and you can find lots more information about all of our other webinars. Thanks, everyone, for coming, and we'll see you on the next one. Bye.